So let's look at systemic blood pressure. And again, we're talking about the systemic circuit, not the pulmonary circuit, which has very low pressure. The rest of this chapter will always be dealing with the systemic circuit. So the heart pumps, we get blood flow, and that's fine, but there wouldn't be any pressure unless there's resistance. And we talked about resistance in the last chapter, so a pressure is going to result because of friction with the walls of the vessels, the length of the vessels, the diameter of the vessels, everything that we went through. So the highest pressure is where the blood immediately leaves the heart, and that's going to be in the aorta. So the aorta of all the blood vessels will contain the highest pressure, and as we work our way around the systemic circuit, that pressure is going to decline throughout the entire circuit till we get back to the heart again. So the steepest drop in pressure we're going to see will be in the arterioles, and then the pressure gradient is what keeps the blood flowing, and that just means as we travel throughout the circuit, pressure gets lower and lower, and blood will travel from high pressure to low pressure, which is why that blood will be able to complete that circuit. So we can see the blood pressure in our aorta and in our arteries. It's high. There's actually a systolic and diastolic pressure because remember there's a pulse of blood rushing through. So we're going to have higher pressure if we take a specific point in an artery and press it down. You'll be able to feel this pulse. So that's the flow of blood as the heart pumps it out, rushing through. And then between pulses, there'll be a pressure as well, which will be lower than when the pulse is there itself. So that's why when in our larger arteries, we have this range of blood pressure, a systolic and diastolic, which is our high and low value. And as we travel to the arterioles, that difference becomes less and less, and we see this steep decline in pressure as we travel through the arterioles. By the time we get to the end of the arterioles, there's no difference between systolic and diastolic anymore. It's just one pressure through the capillaries, through the venules, veins, and then last the vena cavas, the large veins that dump blood back into the heart, where we get to just about zero at that point. So first we're going to look at, for the majority of this video at least, until the very end, we'll look at arterial blood pressure, where it's the highest. And there's going to be two factors that determine the pressure in an artery, and that's its elasticity. Arteries can expand and contract with a pulse. That has a factor when we deal with blood pressure, especially close to the heart. How much can that artery be able to expand and contract with that pressure of blood that comes out of the heart? Of course, the volume of blood. The more blood pumped out into the arteries, the greater volume, the more pressure. The less blood, the less pressure. Blood pressure near the heart is pulsatile. So in our arteries, we have a pulse, which means it rises and falls with each heartbeat. Think of a garden hose that has water in it, but the water's off, and then stomp on the garden hose. That's like the heart pumping. You would have this wave of water flowing through that garden hose. So that's kind of what we're talking about by this term right here, pulsatile. So we've mentioned these terms a minute ago, but now we'll make it official. Systolic pressure is the pressure on the aorta during ventricular contraction, which we see here is the highest pressure on the vessels. Diastolic pressure is the lowest level of pressure. We're talking about the aorta in this example here, when the ventricle relaxes. So in between beats, we have this minimum amount of pressure, which is still pretty high when we're talking about the arteries, especially the aorta. So a pulse is what you feel, that throbbing in your arteries if you press down on one, because the ventricles contract. That forces blood into an elastic artery. It's going to expand it, and then it will contract. So that expansion and contraction at any given point of a vessel is what a pulse is. So it'll have that diastolic pressure when the pulse is actually at that point, and then, a systolic pressure when the pulse is at that specific point, and then a diastolic pressure when that pulse has passed through already and we're in between pulses. So what pulse pressure is the difference between systolic and diastolic pressure. So if we look at, I'm going to go to the next slide here, 120 over 80, well, what's the pulse pressure? 120 take away 80, the difference between those two is 40. So it's an average normal blood pressure of 120 over 80. The pulse pressure is 40. That's the difference between the two. So the mean arterial pressure, MAP, is the average pressure that propels blood into the tissue. So what's the average pressure here? You might think it's halfway, 100. But look at where the line is. It's lower than halfway. So how do you find the mean arterial pressure? And why isn't it right in the middle? It's because the pressure spends longer in diastole than it does in systole. So since it spends more time in diastole, it's going to be favored, the average will be favored more toward the low end than the high end. So if you feel your pulse, there's more time when there's no pulse as compared to when there is a pulse. It's just the space is bigger between pulses than the time it takes for the pulse itself. So the mean arterial pressure is just the average pressure at any given point, and you'll see that's below the halfway mark because it spends more time in dystole than it does in systole. I should say diastole than it does in systole. So here it is. Heart spends more time in diastole, so the mean arterial pressure is not just simply an average of the two. Here's the actual equation. It's diastolic pressure. Let's just use 80 as one for 120 over 80, plus pulse pressure divided by 3. Pulse pressure, remember, is the difference between systolic and diastolic. So 120 over 80, if you minus the 2, is 40. So 80 plus 40 over 3 gives us our mean arterial pressure. And if you actually work that out, you can see it's 93, which is less than the average of these two numbers. That's why MAP is not 100. It's less than that. It's actually 93 because of more time spent in diastole. But pulse pressure and mean arterial pressure both decline as you move away from the heart. And we can monitor these signs in a clinic. We call them vital signs. A pulse rate can be taken, blood pressure can be taken, and of course the respiratory system will be taken into account here, respiratory rate, body temperature as well. We call these vital signs. Typically a pulse is taken at the radial pulse. That's where the radial artery is squeezed against the radial bone to take that radial pulse. That's most routinely used. But there's other pulse points in the body, which we'll see. And pulse points is where an artery is going to be close to the body surface. That doesn't happen too often. Most of our arteries are deep, but there's certain areas where the artery is close to the body surface where we can press against it, sometimes against bone, sometimes against just underlying tissue, in order to feel that pulse point, to take the pulse rate. Pulse points can also be called pressure points because that's a good area to compress to stop the bleeding in the case of hemorrhaging. So here's the most common location, the lateral side of the wrist near that radial bone. We can take a radial pulse. We also take pulses on the common carotid artery, especially during CPR. That's a good location. In infants, we use the brachial artery kind of on the inside of the arm here. This dot might be a little low. You can't feel it there. There's your brachial artery. We have a facial artery on the mandible, a superficial temporal artery in the temples. There's a femoral artery on the inside of the thigh that pulse can be taken there. The popliteal artery in the back of the knee. Around that medial malleolus, there's a posterior tibial artery, and then on top of the foot, the dorsalis pedis artery. So those are your body sites where pulse can be palpated or felt most easily that you should be aware of. So to measure blood pressure, we can, or I should say we are measuring systemic, like we said earlier, this is all on the systemic circuit, not the pulmonary circuit. We use arterial blood pressure. We need a stethoscope for our auscultation or auscultatory method, and we use a blood pressure cuff, which we call a sphygmomanometer. Wrap the cuff superior to the elbow. What that's going to do is occlude or block the brachial artery when you increase the pressure in the cuff. So you're increasing and listening to the brachial artery until there's no more sound. The brachial artery is totally occluded, and then pressure is slowly released from the cuff until you can hear that first little pulse or that first sound. We call that the sounds of Korotkov. So that first sound you hear with the stethoscope, that's the systolic pressure. Normal is less than 120, and keep reducing the pressure in the cuff or in the sphygmomanometer. You're hearing the sounds are going to get louder and louder and louder, and then all of a sudden it's going to disappear. You won't hear it anymore because now blood is flowing freely through the brachial artery. At that point, that threshold is the diastolic pressure, which is normal when it's less than 80. Pressure when the sounds disappear, like we said, because there's no more constriction there. So now we get to the capillaries. You can see there's no more pulse by the time we get to the capillaries. Pressure is very low, 35 to 17, and that's the range when it enters the capillary bed to when it exits the capillary bed. We have that pressure still dropping through the capillary bed from 35 millimeters of mercury to 17. That's a good thing. This low pressure in the capillaries is a good thing because remember how thin these tiny little microscopic vessels are. If it was higher pressure, well, they probably would rupture, and of course that wouldn't be any good. But there's still some pressure, and that's enough pressure to force blood out of the capillaries. Remember how permeable capillaries are with their fenestrations and into the tissues. Then we get to the veins, and the pressure is very low in the veins. 15 milligrams of mercury until up to 0 when we get back to the heart. So not a whole lot of pressure change in the veins, but it still decreases as we're going through the systemic circuit. If we cut a vein, blood will just flow out smoothly, and most of the blood near the surface of our skin are in veins. Arteries are typically deeper. There's only a few areas where it's close to the surface of the skin, and that's a good thing, because if we cut an artery, well, blood is going to spurt out in pulses because of the higher pressure in arteries. So because we have very low pressure in veins, we need adaptations to bring that blood back to the heart, because the pressure is too low to do it on its own. So how does blood overcome gravity and get back to the heart, especially from the lower extremities? Well, when we contract our skeletal muscles, they squeeze on veins and blood gets pushed up towards the heart. Why doesn't it get pushed downward? Well, because there's valves to prevent backflow. So blood has only one way to go, and that's towards the heart. So blood can return to the heart and overcome the low pressure of the veins because of skeletal muscle contractions, milking the blood back towards the heart with the valves preventing backflow. When you breathe, pressure changes between your thoracic cavity and abdominal cavity. When you breathe in, that increases the pressure in the abdominal cavity, which lowers it in the thoracic cavity. And remember, things will move from high to low pressure, moving blood toward the heart by squeezing abdominal veins while the thoracic veins expand. Sympathetic vasoconstriction, so under sympathetic control, smooth muscles constrict. In the veins they can do that as well, and that pushes blood towards the heart.